Ladies and gentlemen, welcome back to another fabulous episode of the Healthcare Trailblazers podcast. I am extremely excited today. I'm excited because I'm sitting with a wonderful Dr. Cunningham. Dr. Cunningham is the Chief of Virtual Care and Digital Health for Providence Health, which is obviously massive. But more interestingly, I think, is founded this incredible project called MedPearl. And there's so much, I'm about to do a panel next week in Washington, D.C., and we did like the prep session, and it's on AI. And what we all kind of spoke about is that there's so much just like pontification and thoughts and theory, and every panel is on AI and healthcare, and there's so much fatigue, and there's like a lot of people that are talking like pie in the sky stuff, and then there's a lot of people that are talking about like very elementary things, and then there's this unique sliver of humans in the middle that are actually implementing. And Dr. Cunningham is one of those, has worked on MedPearl. We'll talk about exactly what it is, but that's why I'm extremely excited. So, Doc, thanks for joining us today.
Thank you for having me. I'm really excited to be here.
What is MedPearl? Let's just start there. Let's jump right in.
All right. Well, before I talk about what MedPearl is, I want to talk about the problem that we're solving with MedPearl. Okay, so let's start there. So clinicians are suffering from a TMI problem. We have way too much information. Medical knowledge doubles every 3 months, and it does not live in the electronic health record. And I'm going to age myself right now, but when I went to medical school and residency, medical knowledge doubled every 20 years. So you can imagine how overwhelming it is to be responsible for all this information that's out there. And then the medical knowledge doesn't live in the electronic health record. The electronic health record is not organized. It does not organize patient data around clinical context. And then there's piles and piles and piles of data accumulating in patients' charts. Like, it is unbelievable. I don't think we thought about it when we started electronic health records. I don't think we thought about what the patient chart would look like 15 years later. It's just a massive amount of information. And so it's not humanly possible for us as clinicians to consume everything that's in the patient's chart and know everything that we need to know at the point of care with our patients from a knowledge perspective. It's reasonable for us to say, hey, we can't know everything we need to know. And so as a result, there is a ton of dysfunction in healthcare, lots of missed opportunities, lots of things that could have been done at the point of care, but the clinician didn't see this lab or they didn't remember to do X, Y, Z. And so specifically what we wanted to focus in on was on referrals from primary care to specialty care. That was our initial use case for MedPearl, because we know that 40 to 50% of the time, when a patient gets referred to a specialist, there's opportunities for improvement, meaning the patient gets sent to the wrong specialist. That just happened to me 2 weeks ago when I saw a patient who waited 8 months to see me, and she should have gone to endocrine. Now, granted, the primary care doctor didn't have MedPearl that sent her to me. But the second thing that happens is the patient doesn't get the best workup or could have been started on a first-line therapy before they see the specialist. So then by the time they get to the specialist has to start the workup, and they have to have multiple visits with the specialist before they get to disposition. And then the third thing that happens is that patients, a lot of times they don't need to see the specialist at all. But it's not primary care's fault, okay? They are literally drowning in information. They're completely overwhelmed, and they're responsible for hundreds and hundreds and hundreds of different diagnoses. And so what we need to do is we need to empower each other as a community to better serve our patients by serving up the right next best actions with the right information within our workflows at the right time with the right patient data points. And so that is the problem that MedPearl is solving. And if you think about it, we have a shortage of doctors, we have major patient access issues, and we have thousands of patients aging into Medicare every day that put pressure on the entire health system. And so in order for us to be able to care for all the people that need care, we need to solve this problem, because it's going to improve access and create more clinically appropriate access. So MedPearl is a clinical intelligence engine that was designed by clinicians for clinicians to create, maintain, govern, and collaborate on building digitally consumable clinical content that is actionable at the point of care. So the back end of it is like a GitHub for doctors to come together in a no-code environment, and then serve that up to the clinicians in a digital assistant that's accessible through the electronic health record. And not only do they get the next best actions of what to do with the patient within this workflow, but they also surface the relevant patient data in the context of that clinical issue. And we have a library of over 600 guides and algorithms that we've curated across the entire clinician community that constitutes about 95% of what a primary care clinician does and sees regularly in their clinic, to help them with that guidance at the point of care. And we're scaled across Providence. We have over 7,000 users and 2 external customers that we're working with as well. So it's going really well. I'll stop there, but that's kind of a description of what MedPearl is and what MedPearl does.
Well, first of all, congratulations. It's not a small feat to start something, grow something, scale something, and so that's really, really incredible. Before I get into a bunch of questions, let's go back to that initial example that you said patient came to you after waiting 8 months, and then, it wasn't even correct. They could have gone somewhere else. How would MedPearl have assisted in that scenario?
Yeah, so in this particular situation, this patient had irregular menses. Okay, I'm a gynecologist, so, I'm sorry if I gross people out by telling this, but, regular menses, and there's a workup that we do typically when a patient has this complaint. Now, the primary care clinician had actually done some of that workup. They hadn't done the whole thing, but they had done some of the lab work. And in that lab work, the patient very clearly had a lab value that was very elevated called a prolactin. Okay. And that elevated prolactin level is caused by a small benign tumor that sits inside our brains, inside a gland inside our brains called the pituitary gland. It's called a pituitary adenoma. That is a condition I don't treat, okay, as a gynecologist. Sometimes I diagnose it, but this one actually had the diagnosis before she got to me. And so she would have been much better served going to endocrinology, who does treat that condition. And if the primary care clinician had had MedPearl, they would have very clearly known and been given that guidance based on this patient's results, that the most appropriate specialist to see the patient would have been endocrine, and here's the right type of MRI that they should order to evaluate the gland. And if it takes several months to get in, here's a medication you can start the patient on. Now, I was able to use MedPearl in that moment because I knew it was going to be months before this patient got in to do those steps myself, but she wasted a visit basically by coming to me because there was already a diagnosis. And I'll give you another example. So chronic cough. This is a really common complaint that comes into primary care. Chronic cough could get referred to allergy, ear, nose, and throat, gastroenterology, or pulmonary, depending on the etiology of the chronic cough. What you don't want is the patient getting sent to all 4, because that's wasteful. And then you don't want to have the patient go to ENT when they should have gone to GI, or go to pulmonary when they should have gone to allergy. And so MedPearl breaks down the guidance in these algorithms and guides to help the clinician decide which is the most appropriate specialist based on the clinical presentation of the patient.
Awesome. So walk me through the actual interaction with the clinician. So if I'm a clinician and I'm seeing this patient, because at this point there's Gen AI, there's all different types of AI, and what is my actual interaction with MedPearl? Like, what's the actual process? Like I want to visualize it.
Yeah. So there's 3 different ways clinicians can access MedPearl today. We have a native mobile app. We have an integration with Microsoft Teams, so they can go and query the database in Microsoft Teams. And then the most common way that clinicians are using MedPearl is through the electronic health record. So when they open up the electronic health record and then they open up a patient's chart, there's just a little button inside of the chart that launches MedPearl. And when they access MedPearl that way, the application is context aware to the patient's chart they are in. So you don't have to like put in a medical record number or something like that. Like it knows that you're seeing, Jane Doe, patient Jane Doe, right? And so then when you start to query, it's search based today. We
Okay.
will have more suggestions based on understanding of things that are going on the patient's chart and the visit context. We'll have more actual suggestions that will come up with topics, but right now the clinicians use a search-based modality to search the content. And then, like I said, when they bring up a guide or an algorithm, the patient's data that's relevant to that guide or algorithm also surfaces at the same time. So it saves us time in reducing chart digging activities, which clinicians do a lot of chart digging and digging for different data points. And then it also, gives the quick, consumable, workflow engineered, workflow oriented guidance for the clinician while they're in the visit. A lot of times,
Okay. So,
sorry, go ahead.
No, finish your thought.
I was going to say the other thing that happens is that we have within the library of content that we've built, we have quick guides and algos, like I said, like tappable algorithms that help with like basically organized around the way we think, right? These massive decision trees that we have in our head as clinicians that we're trained to develop as specialists in particular. We have like specialty specific massive algorithms and decision trees we develop over years and years of experience. We are now able to translate that and codify it in this platform, so we can share, and democratize like what is been locked up in our head and empower those peers of ours that maybe don't have that level of specialty expertise to level up on their the care that they can provide.
Love it. So you've got this giant library of decision trees and data and best practices, and then that will match up with the patient's chart. So it already knows, what's relevant in this giant library to this specific patient. And then do you have to query it specifically? So in the case that you mentioned earlier, would the physician have to ask MedPearl, what is the best recommended because for the patient coming in for XYZ, or does it already know what you're seeing the patient for based on the visit type?
That is the future. That's on the roadmap, is to give the suggestions. Right now it's just query based, but we have vectorized the library and we use AI for optimization of the search experience. And you can put in all kinds of, you can put chief complaints in, you can put scenarios in, you can also just say the word gout or lupus or, abnormal liver enzymes, and it will surface, the right guidance. So it's designed to aid the clinicians, but the future state is exactly what you said. We actually have some POCs built out right now where it will make suggestions for different topics based on abnormal lab findings, or diagnoses and things like that. So that's where we're heading.
Got it. Awesome. And so how do you approach the challenge of, when you cross over into with AI actually affecting patient care, obviously generally in a positive way, how do you approach the challenge of risk? It feeding the provider maybe wrong information or, how do you approach the risk aspect?
So I just want to be real transparent here. At this point, none of the content that we have is generated by AI.
In the future?
Yes.
Conceptually.
Yes. Because that is not from a cultural perspective. We always have a human in the loop. And this is definitely one of the questions that's come up, but it's like, how long is that sustainable? How much faster can you go if you're not using some AI? And we have a whole roadmap of AI. But we believe, at least at this point, we've done a lot of experimentation with having the AI auto-generate content, create content. The AI doesn't know what it's like to take care of patients. They don't know how patients present. It doesn't know the questions the patients ask or the questions I need to ask the patient. Like there's this experiential wisdom based component of 20 years of clinical practice that
Yep.
can't be learned from reading public reading guidelines and research studies and things like that. Like it just doesn't
Yep.
have that ability to do that yet. So the way we're viewing it is, how can I make the content creation process faster by augmenting the people who are generating the content? So by leveraging, if you think about how GitHub evolved, right? It's like where we are now from like where GitHub was when it was first, created. They've layered in more automation and more capabilities. So we see ourselves like right now, we're pretty much 100% clinician generated content. We see augmentation of the clinician content creators as the next step, like a content creation co-pilot, right? To help with the content creation process. And then like auto contextualization of the patient data, instead of us having to go and like annotate what components of the content needs to correlate with patient data. We're going to be able to auto contextualize that data and then a human review of that, so we can speed up that process. So the way we're approaching the AI is augmentation of our content creation team to help them be able to be more productive and more efficient with their workflows, rather than replacing them at this point.
Yeah. And then as far as the actual decision trees, I'm curious because clinicians tend to be very particular about their knowledge. Do you find it to be a challenge that maybe with each individual organization or each individual, I don't know how granular you want to get, do you find that you have to customize the decision trees that are going to be surfaced to clinicians, or do you find that you've done a really good job with like the model is relevant to everyone?
You would think, because this was like a huge undertaking at Providence. Providence has over 10,000 employed clinicians in so many different clinicians in different states with different, backgrounds and practices in rural areas and in urban centers. And you would think that that's what everybody says, that everybody wants to do it differently. But when you actually go back to the core center of like, this is evidence-based medicine, best practice based on guidelines with layers of wisdom, right? So for example, everything follows, guideline appropriate therapy, but there are sometimes things that are not in the guidelines. Like for example, hematuria, which is blood in the urine, which is a very, very common complaint, number one in primary care. And number two is like very common referral to urology, where they say, I didn't need to see this patient, or it wasn't necessary, or they can wait for 4 months, right? Because it's not urgent. Well, what do you think the patient is feeling during that 4-month time, right? How do you think the primary care doc feels when they send the patient to urology for hematuria and the urologist is like, oh, they don't qualify for a referral because they didn't do X, Y, Z. And like the primary care doesn't know, right? So we created an algorithm based on guidelines and based on consensus from the urologists of like when they should be referred urgently, what are the factors to consider, what imaging should be ordered and all that. And then inside the algorithm, there's this section called pointers. Pointers are talking points. They are talking points. I'm a urologist. If I have this patient in front of me, these are the 3 things I would tell them. Guess what? A large percentage of the time, we never find out what's causing the blood in your urine. Okay. The chances that this is cancer is really, really low. So I don't want you to be concerned, right? Like we're going to go through this process. We're going to do the workup. And so it's like us being able to share with primary care, this patient may end up having to wait 4 months to be seen because there's a huge shortage of urologists in this country. It's going to get even worse because 29% of urologists in this country are over the age of 65. So how do we empower primary care to have a meaningful conversation to reassure this patient, or if it's one of the end point in the algorithm where it's like, hey, this is something really concerning, you need to get them in right away. How can we empower them to advocate and say the right things to the patient and to the specialist to get the patient in? So those are things that aren't inside the guidelines, or they're very hard to tease out of guidelines. And so, and those are things that are experiential in nature based on learnings of taking care of patients and talking to patients over years. And so what I found as we built out this content, number one, it's amazing to see some of the specialists who have really, really gotten involved and engaged, where they say that they feel like this is some of the most meaningful and most impactful work that they've ever done in their career. And it will be part of their legacy because they know that they're going to be able to reach so many more patients by democratizing like the knowledge that they have. So this is like from our psychiatrists and our neurologists, where they're suffering from such significant shortages, and they're like, I can scale myself in a different way, right? So it's really interesting to see that anybody who uses the platform can provide feedback. And then within the platform on the back end, we've built a digital governance system, because governance is very important when you're influencing clinical decision making, or you're releasing clinical content and information. And so we have the opportunity for people to have role assignments where they could be reviewers, contributors, authors of content. There's voting. There's governance review levels inside the platform. So believe it or not, once we explain that to the clinicians, let them know they have a voice, they can give feedback if there's anything that they see that they don't agree with. It really hasn't been a big problem. People have been really open and accepting of it. They just need to know that it's respecting governance, that we've been thoughtful about the way that we're putting this together, that it's being reviewed regularly, that it's being updated regularly, that we have an editorial review process in place. Like all of those things, once we explain all of it, it hasn't been controversial, and we haven't gotten like the abdominal aortic aneurysm algorithm that vascular surgery helped us, put together. I'm not getting messages from vascular surgeons in California who disagree with the vascular surgeons in Montana. Like, it's just not happening, because it's guideline aligned, and it has evidence-based practice, and there's just really hasn't been a lot of controversy.
Yeah, I think I think it's such a perfect use case, and I think you've really, you're positioned in a really, really good place to take everything that AI is going to have to offer and be able to only pick out the good parts, and add it to your use case and bolster already, what you're doing already, instead of either, like I said when we started this conversation, like pining for something that's pie in the sky at this point and might become applicable in 2, 3, 4 years, 10 years, I don't know, or maybe not. So I'm really excited for it. I'd love you to take us back, because right now you're scaling this thing. It's exciting. You have success with it. You've proven success with it. Take us back to kind of the origins of MedPearl, because what's fascinating to me is that it's kind of, it's you. I'm saying, and I'm going to kind of focus on you for a second here, because you kind of have this, like, you work in this large system, but you also have this kind of entrepreneurial sense to you, that you're really championing this project from within this massive organization. So first of all, that fascinates me. I'd love to hear how that works in your head, but just take us back to the origin story. When did you see that opportunity and actually think, hey, this is something that maybe I should turn into a product? I mean, it's crazy.
Yeah, if I had known what I was getting myself into at the beginning of this, I don't know if I would have done it. It was like harder than residency to get us to where we are now. It was a lot of nights and weekends, but just became this just like passion project. And I asked my chief technology officer, I'm like, why did you do this to me? Because we were halfway through where we are today. I was like, I can't believe this is just insanity how hard it is to do product. And he was like, well, I knew that the only way we were going to be able to disrupt, so many people had tried to disrupt healthcare, right? And like so many like big players have like tried and failed, over and over and over again, right? Over the
Just
past
now.
many
Yeah.
years. And he said that he realized that the only way it was going to be disrupted was from the inside. And when he and I got connected on this project, he was like, you were naive enough not to know what you were getting yourself into, and you were crazy enough to think that you might be able to change the world.
I love that.
But awesome. I'll tell you the story. So I did not come from a technology background. I just want to start there. I actually come from clinical leadership and clinical operations. So I worked, I'm an OBGYN. I worked at Common Spirit for 9 years before I came over to Providence, and I was a women's health, women's and children's, division chief and a robotic surgeon. And I was like doing a lot of innovation, I guess, and care transformation. If you look at all the things I did, I was influencing clinicians to do and adopt different things. It wasn't necessarily technology, but it was change management and, growth and new programmatic opportunities. And then I moved over to Providence in 2017 to be the chief medical officer of one of the medical groups. So I had a large multi-specialty medical group with like 25 different specialties and GME programs and stuff like that. And I was leading them. And I was doing that for about 3 years. And Providence was in the news all the time about all this technology and innovation and all these things that were happening. But like, I go back to like the front lines to my docs, and they were just like so frustrated. And they were like, none of this stuff is helping us. And if anything, it's almost like making it worse because they keep using us as a playground for all these pilots for stuff that we don't want or need. Like nobody clinical with like clinical operational experience at the front lines was like translating upstream to all these like big partnerships and innovations that we were doing and investing in. And so I felt a little bit helpless, to be completely honest. Like I felt like I was a messenger. Hey guys, like I know it's really hard to use the EHR, and I know that like you want to be able to do XYZ with your patients, and they would bring all these like new technology ideas forward, but like it wouldn't go anywhere, right? And so I just felt like I couldn't do anything for my clinicians that was like meaningful and impactful. And I got pulled into this, like Providence announced a partnership with Microsoft. And so for some reason, by luck, I got pulled into this pretty high level work group to talk about the strategic partnership and to talk about opportunities. And when I got into this work group, I was the only person seeing patients in the entire group of people. Like I was still seeing patients at the time, and I was leading this clinician work group. So I was like, hey, this is my opportunity to maybe influence, right? And this problem with referrals that I talked about was something as a medical group leader, you heard about it all the time. The primary care doctors would complain, like, I don't know what the specialists want. I send the patient to the specialist. They reject the patient. The patient's pissed off. I have to send the patient outside of the system, or it's 5 months for the patient to get in and no communication in that time. They keep sending me these brochures and letters and PDF documents and telling me what they want to do, but I can't keep track of it all. I've got sticky notes all over my desk. Then the specialists are like, primary care doesn't do anything, or primary care sends me crappy referrals. Primary care sends me patients I hear this from the neurosurgeons all the time. These patients don't need spine surgery. They're medical spine patients. Why am I seeing medical spine patients? Because all surgeons want to do is operate. So you don't want to send them things that don't need surgery. You got to send them to the right thing. And so again, it was like this like knowledge sharing issue. So the Microsoft people, I got connected in with them, and then they had these like customer success people who would go out and try to get us to adopt all of their Microsoft tools. And they would come and say, well, why don't you use Microsoft Teams for this or that? And I'm like, that doesn't fit into our workflow. That doesn't help us. That is not like what we need. And they're like, well, what do you need? And I was like, oh, you want to know what we need? So I brought 5 doctors, a pharmacist, and a nurse practitioner in front of these Microsoft customer success guys. And I said, vomit all over them about the referral problem. And these doctors, they were so like fired up, and they were just going on and on and on and on about the referral problem. And these Microsoft people were like, oh my God, like, they were like, whoa. And so they said, well, we might have some ideas. I said, do you have technology to fix that? And so they came back and they're like, we actually have some ideas. They're like, because I said, we have all these like sheets of paper and documents that describe what we want the referrals to do, but we don't have like a technology delivery system. And they said, well, what about a chat bot? And I was like, that's kind of interesting, a chat bot. And so, we tried to go through the typical, like, put in a request to see if we can get approval to do a little POC. And, we did some envisioning with them, but it was moving so slow. And I'm a kind of impatient person. So I figured out that there was like this no-code platform called Power Virtual Agent in Microsoft Teams that was available to anybody at Providence. And so over the course of a weekend, I built a bot and I like loaded all the content that had been harvested across the system and like started experimenting with like massive decision trees in this bot. And then I convinced 40 doctors to pilot it. And I did work with Microsoft to build a feedback loop inside the bot because the bot didn't have a feedback loop and had some analytics, but we wanted to get actual data to say like, when I use the bot during my referral process, it influenced me in the certain ways. And so we could capture some data. And so I did that. So I got like 40 doctors to pilot it. And they were so gracious because it was in Microsoft Teams. It didn't integrate with Epic. It wasn't in the workflow. I mean, and so all these things came out when it was basically like an MVP, right? And so anyways, got data to show that we're onto something. This is a good delivery process. And then for information, this has potential. At the time, it didn't have any like patient data integration or anything like that. And then the next step was that I got in front of the CEO of Providence and pitched the idea to him, and he gave me the thumbs up. And the Providence Clinical Network, at the time, it was David Kim and Amy Compton Phillips leading that whole clinician, the clinical teams, and they gave some sponsorship to us to build out version 1.0 of MedPearl. We did not build out the Power Virtual Agent thing. That was a great proof of concept MVP, but it was not scalable. And it didn't have all the things that we needed. We needed to start from scratch. And then I connected.
Yeah. When was it, by the way?
What's that?
Like how long ago? How long ago was this, sorry?
It's been about 3 years. Yeah.
Okay.
So in 2022, so February of 2022, the first line of code was written for MedPearl with my CTO partner, Adrian Yanes. He's absolutely brilliant. And together, the two of us have continued on in this journey. We built out 1.0, and then in July of 2022, we did our first pilot with over 200 clinicians across Providence. And then in January of last year, it became generally available to all clinicians. And then in August of last year is when we started the contextualization. And then 80% of the library is contextualized now. So
incredible, really incredible. Well, look, I think that like I started off with, we do a lot of conversing and a lot of pontificating and a lot of discussing and about, innovation and what was that other word you used? Disrupting.
Into transformation. Yes. Transformation. Innovation.
Disruption. Yeah. And it's so great. It's so refreshing to see something real. I feel like I'm so happy that I'm talking to you now and not 3 years ago and not next year, because next year you're going to be triple the size. It's going to be a massive, it's going to be MedPearl is going to be on everyone's lips, God willing. And right now is at that like middle stage where you're really still innovating, but for real, and you're implementing your innovation. And so I think I wish you tremendous continued success. And I'm going to be excited to continue to watch MedPearl. Congratulations.
Thank you. Yeah, it's been quite a journey. And like I said, I said I didn't know exactly what I was getting myself into. I mean, as a clinician, we're not trained to build products. We're not trained to be product managers. So there's a lot of skills that I've learned. But I think one of the other things that I think is really important for people to understand about this is just because you're a clinician and you weren't trained in technology or didn't go through the informatics route or whatever, it doesn't mean that you can't get involved in technology and you can't learn, to be a technologist. I learned, and it's really, I truly believe that technology and informatics will be a core competency of being a doctor going into the future. That you really need to have a good grasp and understanding, because it's going to be such a critical component of what we do every day, because we're going to be leveraging so many different tools from a technology perspective to care for our patients in the best way.
Yeah. And I think the other thing to learn from you is that it's not just important for yourself to, for your own future as a clinician, but it's important for the world of tech. Like my good friend and someone I respect tremendously, Graham Walker, likes to say that when clinicians are not involved in all this new transformation and all this new innovation, he gets extremely skeptical, because he's like, where's the clinician in this disrupting technology? And so, I couldn't agree with you more.
Yeah, I mean, there was sort of this sentiment, I would say, where, because I've been in this world now for where I've been going to conferences and talking to people more, like probably 2.5 years. The first year that I was working on MedPearl, I didn't have any connection really into the technology world. But I can tell you that the sentiment I think that a lot of clinicians felt was that it was sort of like, well, we're going to disrupt you, and it was kind of dismissive of us. And it's like, dude, I went to school. You have no idea how long I went to school. You have no idea what it's like to stand in the OR at 2 a.m, doing your fourth, C-section of the night, with 2 other waiting and 3 people laboring and a person with an ectopic downstairs. You don't know what that's like. And so it's just, it was kind of dismissive, of hey, we don't need the clinicians. We can just we just got to go in and disrupt this. And I think the sentiment is very different. I was at Vive and HIMSS this year, and just even all the conferences that I've gone to, that they realize that we are actually going to be a critical part of making the disruption happen. The AI is going to need to be trained, and they're going to need to be trained by clinician workforce, really, to train it so that it actually is reliable, and it's not going to just be able to ingest patient data and guidelines. There's also this human factor of the work that we do as clinicians that's going to be a critical part of that. And I think that people are realizing that, and they respect that, and they understand that. And I have to tell you, I am so concerned about the shortage of clinicians, that we think it's bad now. It's going to be so bad. I don't know if you saw Jesse Ehrenfeld. He's the AMA president. He was just on one of the news channels talking about it. It's we have more than a numbers problem. And so we are not going to be able to take care of our communities if we don't do something technology enabled to expand our reach as clinicians. And so these are the types of things that we need to do to be able to do that going into the future. Because otherwise, Mendel, I don't know who's going to be taking care of you and I when we're old and gray.
Yeah. Well, I couldn't agree with you more. And thank you. I mean, we could talk for hours, but thank you so much for spending time today. This was, I'm really excited.
Yeah.
Thank you.
Thank you.